Dr. Sarkis.
And we couldn't find that fun fact, so I'm hoping we'll start the recording with a fun fact from
All
Dr.
right.
Sarkis.
Fun fact, I'm actually a published poet as well,
Oh,
but that was more than a decade ago. Right.
Still more poetry than I've published.
Um, so I think you have to allow me to share the screen. Are you able to do that, Amy?
Amy, there you go.
you should be all set with that now.
All right. So can you see my screen?
Yes, we can.
Okay. All right. I'm really excited about this. Thank you so much for the invitation. I always love talking about this topic because I'm very interested in this. So I work at the Brigham within the epilepsy division. I also see patients with memory disorders as well. And I'm always interested in seeing older adults with epilepsy, especially those who also have memory problems, because there are a lot of commonalities between epilepsy and memory disorders. And I'll just highlight a few things in this talk, and I'm going to leave ample time for questions, hoping we can have some discussions, and if there are questions I can address. So why is this an important topic? If you look at the incidence of unprovoked seizures, so unexplained seizures that with no clear cause, what you'll see is that uh, you have a peak earlier on in life, then things sort of go down, stabilize, and then after the age of 55, there's this second peak. So a lot of people start developing these unprovoked seizures after the age of 55. And this is data that has been consistent across countries. So this is a combination of data from the US, Sweden, and Iceland showing the second peak after the age of 55. As we do well in terms of caring for patients, people are going to live longer. And what that means is there will be more people with epilepsy, with late onset epilepsy, as the population ages. And I think this issue hasn't gotten a lot of attention. In fact, among persons 65 years and older, active epilepsy is approximately 1.5%, which is twice the rate of younger adults. It's also relevant because if someone has new onset epilepsy and they're older, this is associated with a threefold increase odds of a psychiatric admission and nearly fivefold increased odds of a medical admission. And it's not uncommon for the epilepsy and psychiatric comorbidities to come together. So I have a lot of patients who develop seizures and at the same time also develop new onset anxiety or difficult to treat depression. And those are issues that we need to be aware of. So the key thing is first to get to the correct diagnosis, because there are a lot of things that can look like seizures in older adults. The main one is the mini stroke, the transient ischemic attack. So when you have someone who experiences sudden neurologic symptoms and they're older than 50 or 55, the first thing we worry about is a stroke. And that's why people always end up in the ED. The stroke team is activated. And that should be the number one priority, because a stroke is very time sensitive. You want to give the treatment as early as possible. If it is epilepsy, what usually happens is the same symptoms happen over and over and over. So I have a lot of patients who've been to the ED 3, 4 times with the same symptoms being labeled as a transient ischemic attack. And that ultimately leads to the diagnosis of epilepsy once you do the correct workup. So a stroke or mini stroke is something that can look like a seizure. People can also develop tremors, migraines. People can have auras with migraines. They can have sudden visual disturbances, and that can look like a seizure. There's also a very interesting symptom called transient global amnesia, where people suddenly are amnestic. They forget. They're suddenly amnestic for around 24 hours. And one key feature in this disorder is they repeat the same question over and over this 24-hour period. And then it resolves. And most of the time, it's usually, this is an event that will happen once in someone's lifetime. So another seizure mimic is this transient global amnesia. The other thing we definitely don't want to miss is an electrical issue in the heart. So a heart arrhythmia, the heart suddenly stopping, not enough blood pressure to the brain can cause symptoms that can look like seizures. And so that's something that should always be on the radar. Non-epileptic seizures, so functional seizures, are also common in older adults. And should be kept in mind. And psychiatric symptoms like panic attacks can also look like seizures. So it can be complicated. And sometimes the only reason someone ends up in the seizure clinic is when they have their first tonic-clonic seizure. So they may have had symptoms for years, and suddenly when they have the first tonic-clonic seizure, the doctors then realize, oh, we've been missing epilepsy. This is epilepsy. We need to send them to the seizure clinic. So the next question is, what might cause a seizure in an older adult? And the first cause is, depending on the study you look at, is going to be a stroke. Whether that's a stroke that is known or a silent stroke, it really depends on the location. So it has to be cortical, not deep. So deep strokes caused by high blood pressure are probably less associated with seizures. Some people believe they still put you at risk. But if you have a stroke affecting your cortex, you're more likely to develop a seizure, especially if this is a stroke that was embolic. So if you had a clot that broke off into a number of small clots and that went to a number of brain regions, that puts you at risk of a seizure. So ischemic stroke is one, so vessel blockage. There's also hemorrhagic stroke where you have a blood vessel that bled, especially if it's cortical, that will put you at risk of a seizure. So after you have a stroke, your risk of epilepsy actually suddenly jumps 20 times. The other thing to keep in mind is there are studies showing that if you have seizures, your risk of stroke goes up. And so that seizure might be a symptom that there are vessel problems in your brain, putting you at risk of a stroke. And later on, I'll talk about, what we can do about this. So the top thing that causes seizures later on in life is a stroke, especially if it's hemorrhagic and cortical. There are, however, a number of other possibilities. Low sodium is common. Someone who's placed on, a diuretic, a water pill, or who's placed on an antidepressant. If the sodium drops very quickly, you're more likely to have a seizure. Someone who's diabetic and takes more insulin than they were supposed to, and they suddenly have low blood sugar, that might cause a seizure. Trauma and falls are common, especially if there's bleeding in the brain, that would put you at risk. And then something that we've underestimated for years is how common seizures are in people who have memory disorders, including Alzheimer's disease. And it can actually be as high as 20%. Another thing you don't want to miss as a cause of a new seizure in an older adult is a brain tumor. And there are several types of brain tumors. So whether it's a meningioma, where the tumor is in the covering around the brain, or a glioma, which is inside the brain, it's a brain tumor, or a metastatic lesion. So someone who has lung cancer and the brain has not, the cancer has now spread to the brain, that might trigger a seizure as well. Another very common one is drug-induced, someone being placed on a medication that makes them more prone to have seizures. Alcohol is a big one. So if someone's chronically consuming alcohol, over-consuming, and then suddenly stops, they're more likely to develop alcohol withdrawal seizures. There are other more unusual causes of seizures in older adults. Autoimmune is one. Usually these diseases are most of the time what we call explosive. So the seizures start and they don't stop, and they're daily, very frequent. You might also develop other symptoms such as rapid memory loss, psychiatric symptoms. And so autoimmune disease is another treatable disorder that you don't want to miss. And then another very common cause is a blood pressure spike. So your brain likes a steady blood pressure over time. So if there's a sudden spike in the blood pressure, your blood vessels might not be able to handle that, and there might be some leakage around them, and that might cause a seizure. And then one thing to highlight is it's not uncommon to find a clear cause. It can be very frustrating both for the physician and the patient, and this can be up to 50% of the cases. It's always a good idea to keep looking, to look for clues, to get the right scans, which I'm going to talk about soon. But 50% of the time, we might not find the cause. In terms of risk factors, what might place someone at risk of a seizure? Just like any seizure disorder, if someone has a history of depression, they are at a higher risk of developing seizures during their life, including as an adult. High blood pressure I've spoken about, so that is a risk factor as well. A big one, which I would definitely like to highlight to the group, is obstructive sleep apnea. So as we grow older, the risk of obstructive sleep apnea goes up. And so these oxygen drops in sleep are a big seizure trigger, and they're another treatable cause in someone who has a seizure disorder. So if someone's seizures are not well controlled, one place to look at is sleep, to screen for sleep apnea, and to treat it if you find it. And then finally, anyone who has had a history of head trauma, especially if it's severe, where they lost consciousness or they needed brain surgery, or if they were bleeding, that also puts them at risk of seizures. What do the seizures look like? So the most common one is the tonic-clonic one, where there's loss of consciousness, sudden shaking, stiffening, and so that's, the old term for that was grand mal, but that's the most common one that can happen. It is not uncommon for this to happen during sleep. And again, it might be because of the sleep apnea. So I have a lot of patients who experience their first seizure in their sleep. And then when we look at their sleep, we identify severe sleep apnea, and that's likely the trigger for their first seizure. Another seizure is what some people term absence, but the new term for this is focal with impaired awareness. So they're zoning out, they're staring ahead. They might experience some lip smacking or might have these automatic movements in the hands. That's very common in older adults because most seizures that are starting in older adults are coming from the temporal lobes. And when the temporal lobes are involved, those are the symptoms you usually get. In older adults, it's also more common for them not to have tonic-clonic seizures, for seizures to be very limited to specific brain areas. And one of the common brain areas involved is the language area in the temporal lobe. And so there are patients who only experience very brief episodes of difficulty speaking, expressing themselves, lasting a few minutes. And those are usually the patients who are always sent to the ED due to concerns about a stroke. But ultimately, if this keeps happening, you have to start thinking that it's probably an electrical issue and they're having seizures. There's another interesting a symptom in older adults called transient epileptic amnesia. So I've had a few patients who actually were brought to the hospital because They forgot major events in their lives, recent events, attending a wedding, attending a funeral, someone in their family passing away, but they were still able to go to work without any issues. So they have these memory lapses specifically affecting memories that occurred within the past 3 months to a year. There are also the auras. So the auras are going to be subjective symptoms. The common ones, again, because the temporal lobe is involved, is going to be a rising symptom in someone's belly and a déjà vu, so suddenly things feeling familiar to you. Another common one I've seen is sudden flushing, so people suddenly experiencing this recurrent flushing sensation. So that should make you think of seizures as well, especially if they keep happening over and over. Another clue is if they're waking you up from sleep. So if any of these symptoms are waking you up from sleep, that's another clue that you might be dealing with seizures. Another key thing to know is most seizures, if you time them, are going to last a few seconds up to 2 minutes. So the average seizure really should be less than 2 minutes. And that's why if you hear about symptoms that are transient, occurring less than 2 minutes, and recurring over and over again, a seizure disorder should be a consideration. In older adults, the issue is what happens after the seizure. So the post-ictal phase can last hours to days, and I've had patients who needed weeks to recover after their first tonic-clonic seizure. So the post-ictal confusion period can be very prolonged. And again, to highlight, you expect the same symptoms to happen over and over because it's the same area being involved by the seizure disorder. So when we're suspecting someone of having seizures, what are tests we can do? One of the common tests we do is the EEG. So we place electrodes on someone's head. Sometimes we just rely on a 20 to 30-minute EEG. Someone comes in, the electrodes are placed. We watch them in the lab for 20 to 30 minutes, and then that's it. Sometimes if you want to delve some more into what's happening in sleep, and if someone's having frequent events that you really want to capture, you can actually send them home with an EEG, usually for 1 to 3 days, and you can add video to that test to try to capture what's going on at home and analyze the EEG. And sometimes, even with this workup, you're unsuccessful, and your only solution is to actually bring someone into the hospital to the epilepsy monitoring unit and admit them, usually between 3 to 14 days. So you monitor them, take them off medications, try to trigger something in the hopes that you capture the event that's happening to them at home. The other key workup is going to be the MRI, and not all MRIs are the same. So you want to pick the right magnet. You want to tell the radiologist that you're concerned about seizures. If this is someone's first seizure, you have to make sure that the MRI was done with contrast. So you can't just assume that if someone has a report of a normal MRI that, there's nothing causing these seizures, we're fine. You really have to look at the MRI yourself, make sure the right scan was ordered. And it's often a good idea to repeat that MRI at a later time point because things might show up, 3, 6 months later. You should also do some common labs. As we said before, sugar and sodium can be seizure triggers. So you want to make sure the sugar wasn't too low when the seizure happened. You need to look at kidney and liver functions. And those are usually the standard tests. You want an MRI, you want EEG telling you about what the brain waves look like, ideally capturing some sleep, and the blood test. And it's always a good idea if there's a witness to get information from that witness. What did they see? How did this start? What did the patient look like after the seizure? And have you seen this before? And then to ask the patient, what was the first symptom that happened to them? because that might be a very helpful clue. That the aura is very helpful because it's usually either the area that is seizing or very close to the area that triggered the seizure. And then there are other tests that will really depend on the circumstances. So we would check autoimmune labs if we think someone is presenting with a typical autoimmune disorder. There are other more advanced tests that we can do, like a spinal tap or a PET scan. We might get neuropsychological testing, which is basically a memory testing session for around 4 hours, especially if someone is having cognitive complaints. Again, to better understand their brain and how best to help them. Next, so once you've diagnosed this the seizure disorder, you want to treat it. And if there are reversible causes, you need to address that. So if you've identified the medication that may have been responsible, you want to stop that medication. If you haven't been able to identify anything reversible, then you would start a medication. The good news in older adults is you're more successful in stopping the seizures. So 80% of people will respond to 1 or 2 anti-seizure medications. The most important issue, and this is where it gets tricky, is that the medication has to be well tolerated. So older adults are more likely to experience side effects, which is why we always have to start with very low doses and make sure they're tolerating the medication, and usually build them up in the system very slowly. And so common medications that have a good track record in older adults are levetiracetam, which is Keppra, lamotrigine, which is Lamictal, lacosamide, which is Vimpat, and in some cases, Neurontin can work. Now, this is a very short list. We're lucky because we have more than 20 seizure medications, if not 30 by now, that we could try. It really depends on what the seizure was like, how soon do you want to control the seizures, are there other medical problems that you need to be aware of? And then cost also comes up because some of the newer medications that are brand name can be costly depending on your insurance. So if someone's going to get started on levetiracetam, they probably need half the dose a younger patient with epilepsy needs. What you also have to keep in mind is these drugs are usually processed by either the kidney or the liver or both. So if someone has some kidney insufficiency, if their kidney is not working at 100%, it is less likely to clear the drug efficiently, and the patient might need much lower doses than, let's say, someone who doesn't have kidney disease. In special situations where someone's getting dialyzed, the drug will most likely get dialyzed as well, and it's not uncommon for them to need a second dose after dialysis. What are common side effects of the medications I've spoken about? So any brain medication can cause fatigue. That's probably the most common one we see. The more you increase the dose, the more you add medications, the more people start experiencing fogginess, their processing speed changes. In older adults, another big issue is balance. So some of our medications not only affect the cortex, but they also affect the cerebellum, which is your balance center in the back of the brain. And that will make them more likely to fall. Their reflexes are not the same, so they have to be extra careful. Tremors are common with specific medications. And some medications make people more anxious or more depressed. So that's something to think about. Another thing we've realized over time is some of the older drugs we used to use, such as phenytoin, phenobarbital, carbamazepine, actually have bad effects on your vessels, whether in the heart or brain. So they can put you at risk of a stroke or heart disease. And another big issue is bone health. These medications can deplete your vitamin D levels and affect your bone density and put you at risk of a fracture. So ideally, if if at all possible, you want to avoid these medications. Sometimes they're the only medications that work for someone, and sometimes they're a medication that someone was started on 30 years ago, and they're uncomfortable changing them. Another thing to keep in mind is a lot of older adults are on 5, 10, 15 medications. So you have to be aware of how your seizure medication is going to impact other medications. In general, the older medications that affect the liver are the more problematic, because once you activate the liver and make it more hyperactive, it will start processing other medications faster. So it will quickly deplete your vitamin D, it will lower your hormone levels, it might affect your blood pressure medication, your blood thinner medication. And so your doctor has to keep that in mind if they're going to add anything that's going to affect the liver. Valproic acid is unique because it actually does the opposite. The liver becomes less efficient in processing some medications, so their levels start going up. The other thing to keep in mind is seizure first aid, and the seizure first aid is the same for older adults. The key is to make sure they're safe, to turn them on their side, make sure they're breathing okay, that they didn't hurt themselves, and you know, just not putting anything in the mouth, and calling 911 if needed. What about emergency medications? There are many rescue medication options right now, which is great. So if someone's actually awake and they can take a pill, you can use an oral rescue medication like lorazepam, Ativan, Klonopin. There are some medications that are liquid, so you can sometimes squirt the medication in the mouth or a feeding tube. And then more recently, two companies have come up with nasal sprays. Those are ideal if the patient is unconscious or in the middle of a tonic-clonic seizure. Those nasal sprays can be used. I'll also briefly touch upon other treatments that are also used in epilepsy that I get asked about a lot. So what about diets? So we know the ketogenic diet and the modified Atkins diet work for epilepsy, but you really have to be committed to them. If you're gonna try a diet for your epilepsy, you have to work with a nutritionist and an epilepsy doctor who specializes in this. It's really hard to implement on your own. You want to do blood tests. You want to make sure that cholesterol levels are not suddenly skyrocketing because your diet is suddenly shifting to a high-fat diet. You really have to be motivated, and you have to be aware of the risks of these diets. I'll also comment a bit on marijuana because I get asked about this a lot. So Epidiolex, which is CBD, has been approved for specific epilepsies, but not for focal epilepsy yet. I think there are some trials underway. So as an epilepsy doctor, I cannot prescribe Epidiolex for someone who's older. And what you're going to get from the dispensary is usually either at very, very low doses or is not pure enough to help. And you also have to keep in mind that CBD is a chemical. It is a medication. You shouldn't consider it a supplement because it can affect the liver and it can interact with other medications you're on. So it's always a good idea to be open with your doctor if you're considering this as a treatment, to have a discussion about it. And sometimes I've had patients who really wanted to try CBD from the dispensary. They let me know, and we do some blood work before and after. But again, the doses for epilepsy that we use are very, very high doses, and it's going to be very costly to pay out of pocket for this. Another treatment option that can be curative is surgery. In older adults, because the seizures are mostly coming from the temporal lobes, the surgeries are straightforward. However, the complication risk is a bit higher than a younger patient. And your surgery options are either to do a temporal lobectomy, which is the bottom picture. So if the seizures are coming from the temporal lobe, is to remove around 4 to 5 centimeters from the temporal lobe. This is usually an aggressive resection. It's sometimes necessary to cure someone. However, if you are affecting the language area, memory and word finding symptoms will come up, and being older than 50 or 60 is a risk factor for more decline after such a surgery. Another surgery we now favor is the laser surgery. So in this case, you're only going after a more localized area in the temporal lobe, the hippocampus. And so the outcomes are usually better from a cognitive perspective. But because the surgery is less aggressive, it tends to be a bit less successful in terms of completely stopping the seizures. So that's why you need a team approach behind this. You need to be aware of the risks. What are your goals from the surgery? What are risks you're willing to take? Ultimately deciding with the team what option makes the most sense for you. There are other treatments that don't involve removing tissue or lasering tissue, and those are the pacemaker type of devices. So these are devices that modulate the brain. They need time to work. They don't work immediately. You need at least 6 months to a year to start seeing some benefits. And those devices can be placed in different areas. So the first one that came out was the vagus nerve stimulator. So here you're stimulating the vagus nerve. The other two devices that are more recent are the responsive nerve stimulator, where you're actually putting electrodes on the brain area you think is triggering seizures, or the deep brain stimulator, which is the surgery they use in Parkinson's. But in epilepsy, what you're doing is you're actually placing the electrodes deep in the brain, usually in the thalamus, to modulate the brain. And again, you're not taking any tissue out, but these are not curative surgeries. Your goal here is to improve the frequency and intensity of the seizures. And in most scenarios, you're going to drop the seizure frequency by 50 to 80%. Other risks to keep in mind, the risk of stroke I've highlighted. So for some reason, if you develop seizures later in life, you're at higher risk of stroke. So it's very important to keep an eye on blood pressure and cholesterol and make sure those are under good control. Having seizures later in life also raises your risk of dementia. And sometimes these seizures can be a symptom of Alzheimer's disease. And so if you are having any memory problems, you should definitely mention that to your doctor so that the right workup can be done. And then the risk of fractures is higher. So I've mentioned that some medications can affect bone health. Sometimes you need vitamin D supplementation. Unfortunately, in the Northeast, a lot of us are vitamin D deficient. And a lot of patients with epilepsy, sometimes due to concerns about seizures, stay home a lot, so they don't get enough sunlight. They're not moving enough. And that also increases their risk of osteoporosis and fractures. And that's why sometimes getting bone scans can help to figure out what the risks are. How can you take care of yourself? So a lot of research has been done recently about brain health in general, and this also applies to anyone who has a brain disease, especially if they're older. So taking care of yourself means avoiding substances that can harm your brain. Excessive alcohol use is a big one. Trying to avoid medications that can trigger seizures. Sleep, as I've said, obstructive sleep apnea is a big seizure trigger, so getting a good night's sleep, aiming for at least 7 hours if you can. And if you're not sleeping well, having a discussion with your doctor and getting a sleep study. And then taking your medications on time, using a pill box or a phone reminder also helps. Another big area that a lot of people are now focusing on is social isolation. So loneliness is actually a risk factor for dementia. So you need to stay socially engaged, find hobbies you enjoy doing. What you don't want to do after retirement is to spend your time just watching television. That's not good for your brain. It's a very passive activity. So I have, patients taking up singing, gardening, traveling is good. Reading, Sudoku, anything that will activate and stimulate your brain. Exercising, going out for walks, monitoring your health, making sure you have a physical regularly, that your blood pressure is under control, that your cholesterol is under control. And then going back to diet, so the Mediterranean diet, rich in vegetables, olive oil, fruits, nuts, and fish, is just really good for the brain. So the more of that, the better for you. And then finally, at the Brigham and at MGH, we are doing some research projects looking at people who have unexplained seizures later in life. So if anyone's interested, please feel free to contact me. This is the email for the Brigham study. There's also a study at MGH as well. And I hope you found this helpful. I'm happy to take any questions.
Thank you. We do have some questions in the chat. Nitesh, can you kick us off?
Yeah, thank you, Dr. Rani, for your important presentation. It was very nicely presented, and you included most of the topics for the seizure that needed for all the patients. And we have in chat, the first question is what is the importance of impact of seizure control when considering possible comorbid conditions like dementia, stroke?
Seizure control is really the number one priority. So uncontrolled seizures can lead to, in some people, accelerated cognitive decline. Your brain has to reset every time after a seizure. We think some seizures can cause some brain damage, so that is a big concern. The other concern is, especially the worst are the tonic-clonic seizures. Your number one priority is to really stop all tonic-clonic seizures, because tonic-clonic seizures can affect oxygen. They can trigger heart arrhythmia. So I've had patients who only have atrial fibrillation when they have a seizure, and that's going to put you at risk of stroke. And unfortunately, I didn't mention this, but sudden unexpected death in epilepsy can also occur in older adults, and I've had patients unfortunately pass away. So I'd say prioritize the tonic-clonic seizures. That's number one. If you're only having auras, we're not sure how bad these auras are for the brain. You should try to control them, but I have some patients where even after 2 or 3 medications, we can't, and some are willing to live with that.
Maureen has a question.
Okay, my son has seizures, and he says that weed will cure it. If he goes to the dispensary and he thinks weed cures it. Is that so or no?
So there's no straightforward answer here. If you're going to use CBD as a seizure medication, the doses the dispensary gives you are not enough. There are some patients who are treating their anxiety and their sleep by doing this. And sometimes by helping your anxiety and sleep, that which can serve as a seizure trigger, that improves your seizures. But you can't rely only on the dispensary as your only epilepsy treatment. You really have to rely on the medications first. And then a good question is your son treating something else? So is it the insomnia? Is it the anxiety or stress that they're going through?
Now, what about the pen, where they put the weed in the however it goes, like the vape pen has weed in it, I guess?
So again, are they using it for sleep or anxiety? The problem with this is THC has been shown to cause cognitive slowing. There's also some recent data showing there's a higher stroke risk in people who smoke weed a lot. And so there are some health concerns related to this. It's always a good idea to ask why this is being done, what are they trying to treat, and to have a conversation about the risks involved.
He does have medication, but weed, he says, cures everything.
It's very common. A lot of our patients smoke. I think it's partly self-treatment of anxiety or sleep.
That's what he says.
Some of them, it's boredom, and that's where, having some activities during the day help.
So should he not smoke weed, or should he?
I'd have a discussion about the risks of weed involved. So it is like adding another medication to medications you're already on. It will slow you down. And there's also a higher risk of stroke with it. So those are the risks. And then I assume your son is an adult, so,
He's 30 and he's had multiple seizures, so he said the weed cures it, and my sister says no.
I mean, your role is to educate him, guide him to the right resources, and it's going to be his decision ultimately.
Right, and I'm afraid I think the weed causes the seizures.
So the data there is mixed. There are some strains that are activating that can trigger seizures. Most people who smoke weed will not trigger seizures by smoking weed. I'd be more concerned about the other things rather than it triggering seizures. I'd be more concerned about the cognitive and vessel impact of the weed.
Yeah, because he gets everything right from the dispensary. But he's 30, I can't tell him what to do as much as I want to.
Yeah.
And I got one more question so other people can talk.
Sure.
Okay, he lost his license in October for 6 months. Now we kind of had an episode like maybe a month ago, and he fell in his room, but I didn't witness it, and he was out of it. Like, he didn't know. He said he was sleeping. Now we're trying to get his license back now. We have an appointment on the 21st. Do you think that since he had a little episode that he would get it back, or is that something they would stop him? And how long would it be again if they say no for his license?
So you'd have to have a discussion with his doctor. It's all about whether there was loss of consciousness. Did your son lose consciousness with that event? And if the evidence is pointing towards that, then the clock resets. Then you have to wait another 6 months. Ultimately, it's going to be your doctor's decision because they're going to have to sign off. And so that's the discussion you have to have. The more information you can provide, the better. What were the circumstances? What happened before? Any triggers? Did this look like the prior seizures? And then your doctor has to decide.
Okay. Thank you for giving me information.
Actually, can I say something real quick? And Maureen, I can answer or kind of give you guidance about a license. Regarding the license, I had actually had a seizure in behind the wheel, believe it or not. And I lost my license for 6 months, and then a little over 6 months, I got another one, and I lost it for 9 months. And then after that, and since then, I was able to get stabilized, I guess is a good way, on my medication to get everything consistent. And I mean, give or take, it took me about a year to get mine back. And that was with the approval of my neurologist.
Well, he had a seizure behind the wheel,
Mm-hmm.
but he wasn't driving. He was just in my parking spot. And I heard the car revving, and I went out there, and I couldn't get to him, so I called the police. But when I talked to them later, they said they did not report him. And my neurologist said they didn't report him, but the neurologist is a mandated reporter, just like the police, right?
No, it depends on the state. In Massachusetts, they're not mandated to report to the DMV.
So then who would have taken his license?
No, most of the time it's usually the police that reports him, and then the license is taken away. If the police did not
Yeah.
report him, the doctor is not legally obligated, but doctors can report, especially if they are concerned about, the patient's safety or the safety of the community. So if we know someone is actively seizing, they're a risk to themselves and people around them if they're driving.
But why would they say they didn't?
Who said they
The
didn't?
police, when I asked them if they took it away, they said, or they reported him, they said they didn't.
I don't know what the circumstances were.
Yeah, I've been in that situation too, Maureen, and I think that I think it's a bottom line of who reports it and who doesn't, and you have to focus on the safety again of him and others. And it's really easy. I remember when I first, started having seizures again, I would wake up from the seizure and my first thought was, oh my gosh, my license. So it's a really hard thing to let go of, but you really should, regardless of whether or not they report it. I think I might even legally still have a license. I haven't driven in like 10 years, because it's not necessary for my MD to report it. An MD, like he said, can report it. Maybe the police report it. But the bottom line is, if his doctor says, it is safe for him to drive, then go to the RMV. They'll give you the process and you follow it. And you really should be focused on his safety and the safety of others. I'm worried we're going to run out of time. I know
I know I just got one more quick thing.
Oh, okay, go ahead.
Is there any way that with people that like him and me, but no, I don't need that, but is there any way he can get rides through to work and from work because he has no license?
That's something that we work with people on. I know that you work with Faith, but Shelby or Natesh, can you take a note and let's follow up with her and talk about transportation and her son. Unfortunately, I don't even know his name. What's his name?
His name is Kyle.
Okay, I figured he had a name other than identified as something other than a seizure disorder.
Yeah, so if somebody could, reference me or give me some help on that or guide me in the right direction. I mean, I'm not on a bus line. Lyft or Uber could bring him there, but it's like $30, at least $30 one way. And if you add that, for the whole entire week, that's like half his paycheck.
Yeah, it's never simple. I will tell you, it's never simple, but it is an obstacle that we work on and we work with people on very regularly. So
we have another.
Go ahead.
Okay, well, if you guys can help me, I'd appreciate it.
Of course.
Maureen, we will reach out to you outside.
Anything you can help me with, I greatly appreciate it. You guys are really good.
Another message that we have in the chat, or a question, is what are some of the added issues you address when considering medications like osteoporosis, mobility, stability, etc.?
So I always factor that in to try to limit the options I'm going to choose. So if I have someone who's already falling or has a neuropathy, who's already unsteady, I'm going to try to avoid a medication that might put them at higher risk of falls. If I have someone who already is known to have osteoporosis, I'm going to try to avoid any medication that might worsen that. It really depends on what's the medical history, what are other symptoms the patient is telling me about. So if someone's already anxious or very depressed, I want to avoid levetiracetam, Keppra, because I might make those symptoms worse for them. If someone's unstable, I want to avoid anything that might affect their stability. So it's always a good idea to discuss with your doctor your medical history in detail. What are current symptoms you're having? Are you having any cognitive symptoms, any psychiatric symptoms, any sleep issues? And those are all things that will help your doctor pick the right medication for you.
And there is another question like, are there hypotheses for why older adults have 14% higher rate of seeing efficacy with medication than the overall population or individuals treated with anti-seizure medications?
So I'll mention a few hypotheses. Nothing is well established. One hypothesis is the network hypothesis. So if you have an injury to the brain that occurs while the brain is developing, that area, and depending on the wiring and connections of that area, can become so well established, it becomes harder to treat. Versus in older adults where the wiring has already been established, that area might not become as refractory. The other thing might be is the ease with which this area can spread to other areas. So we know the connections change with time. And so spreading to other areas might be more difficult. Another theory is medications go to the brain more in older adults. So because the blood-brain barrier around the brain is a bit more porous, so it allows more medication to go in. Those are all theories, but there have been some good studies out of England showing that sometimes people are very refractory earlier in life, and then as they grow older, as their brain changes, they become more medically responsive. So there's something about the older adult brain that makes it easier to treat. And those are some hypotheses that people have come up with.
Thank you, Dr. Sarkis. This has been very enlightening for everybody. If there are no other questions, then we are going to say goodnight.
I think we got everything. I was just basically wanting to know about the weed and the driver's license. That's it. So I think you kind of covered that for me.
Good luck, Maureen. I'd definitely connect with the Epilepsy Foundation about, research.
Yeah, well, we're going to see his neurologist on the 21st, so we won't know the answer until we see him. My fingers are crossed, but I really don't know.
Yeah, if there's any concern, you want to just be careful.
Yeah, he wants it back so bad, and I get it.
One thing I want to quickly ask, kind of relating to Maureen's question, Dr. Sarkis, are you able to kind of quickly share like the differences between preparing the CBD in a dispensary versus a medication that gets prescribed like Epidiolex, and like the factors that go into all of that?
So I'll preface this by saying I'm not an expert, but purity is, because Epidiolex is very well regulated, and you have to have a specific level of purity of CBD for it to be efficacious. And there have been studies where they actually got random samples from different dispensaries, and the purity of the CBD in the samples from the dispensaries were very variable, where you have someone with only 40% purity, others 60. What you actually need is closer to 90 and more than 90. And usually the doses, like if you calculate the dose needed for someone with Lennox-Gastaut based on their weight, I actually, did this with one of my patients. If they actually wanted to buy this dose out of pocket, it would actually cost them $1,000 a month. But we did that a couple of years ago. And again, my hope is there are clinical trials right now in focal epilepsy. If they're successful, we have the science behind this for focal epilepsy, for epilepsy in older adults. It's well regulated. We can then prescribe it. In the meantime, it's sort of, you don't know what you're getting.
Thank you, Shelby. That was a good question. And thank you, Dr. Sarkis, for giving us that information. Thank you so much for your time tonight, Dr. Sarkis. We really appreciate it. And thank you, everyone who could join us. Thank you, Nitesh and Shelby, for helping out with the moderating the chat. Have a good night, everyone.
Bye, everyone. Nice talking to you, doctor.
All right. Best of luck.
Have a great night.
Thank you so much. Bye, everyone.
Bye-bye.